Hello, my name is Liz Sinclair, as most of you know. Welcome to AW's Community Lecture Series. We're excited to have Libby Parker here today. She is a dietitian and eating disorder specialist, as well as a treatment consultant, and a friend. And we're excited to have her. It's going to be a sort of Q&A style this morning. So if you have questions, please put them in the chat or raise your hand, or however you want to ask your question, feel free to do that. Libby is super versed on this topic. So yeah, feel free to ask her whatever. Thank you again. And you can take it away.
All right. I'll give a little bit more of an intro, but thank you so much, Liz. It's been great getting to work with Academics West and all of you wonderful people. So I'm really happy to be here. And yes, as she was saying, I am an eating disorder specialist. I've been working in the field of eating disorders for over 11 years now, and primarily as a registered dietitian in multiple different settings. And then in the last year, I have also switched into doing treatment consulting and placements nationwide. So I've been working with some pretty acute cases, helping get them into higher levels of care at various facilities across the nation. So working with all that. And as you probably know, eating disorders don't exist in a vacuum. So usually there are comorbidities going along with that. As I'm sure, if you are working with kiddos with eating disorders, they probably have other issues that are coming up. This can look like different mental health diagnoses, behavioral things, other addictions. We can get into all that. I'm going to adjust my curtain in just a moment because the light is starting to come in and hit me. So let me do that and then keep talking, but start thinking of your questions. Okay, it's that time of day when the light's just going to hit my eye if I don't do that. Okay, what else did I want to say before we jump in here? Yeah, I really want this to be your time to ask any questions that you have around eating disorders. What are they? What do they look like? How are they presenting? What can we do about it? At home or at school? When do we need to be referring to other providers? What does a treatment team look like? What are different treatment options? What are eating disorders? Like literally any question goes. There are no dumb questions. I know this is a topic that doesn't get talked about nearly enough. It's, still unfortunately a very taboo topic in the world. I think a lot more people are, getting comfortable with saying, oh, I go to therapy, or I have depression, or things like that. A lot of people still aren't admitting or perhaps are in denial if they have disordered eating or an eating disorder. So that can be really hard to navigate. And I just kind of want to riff on this for a moment too. Basically all types of eating disorders, whether it's, something as we think of traditionally restrictive like anorexia nervosa, all the way up to binge eating disorder, they all stem from a place of restriction. So even someone who is binge eating, binging and purging, any of that kind of stuff, there is an element of restriction in there, whether that is restriction of overall calories or restriction of things that they really love. It could be, oh my gosh, I ate so much last night, I'm gonna be good and skip breakfast or something like that, or I'm not gonna let myself have chocolate again, and that tends to fuel the eating disorder. And why I bring this up beyond just kind of understanding that as a baseline is that the restrictive brain, when we go into actual caloric restriction, as that continues over time, and as little as 10 weeks of not consuming enough food to fuel your body's natural needs, again, whether this is by eating disorder, by diet, by famine, what have you, just lack of nutrition, the brain actually starts to shrink. And that makes thinking patterns much more rigid, which is why as someone progresses into their eating disorder, their thinking becomes more and more rigid. Their rules around food and behaviors become more and more strict, and it feels like it's kind of a snowballing effect, and why they will deny that there's anything wrong. The cognitive function, the cognitive distortions really get out of hand. So it's like you could present them with the greatest scientific logic in the world, and they're going to go like, yeah, but that doesn't apply to me, when in fact it's really applying, and you can like see it straight on. So I just wanted to put that in there for some context as well. A lot of the people you might be seeing, this could be friends in your life too, they're not going to believe they have a problem. They're not going to necessarily present like you would traditionally think an eating disorder would present. And if you try to approach them, they might really fight it. So just want to throw that in for some context. Let's go ahead and open up to questions. If you want to raise your hand, and we can just come off mic. I think that's going to be easier. But we have one in the chat as well here. So I'll start with that. But yeah, if you just want to like put up the little hand emoji thing, and then we can just call through people. Okay. So Carmen's asking, how are eating disorders diagnosed? That is great. So eating disorders, and I'm not sure if everyone on here is a clinician or if we have parents or other people. So eating disorders are diagnosed using the criteria in the DSM-5, like any other mental health diagnosis. So Diagnostic Statistical Manual of Mental Disorders, 5th edition now. They need to be diagnosed by anyone who can make those types of diagnoses. So therapists, psychiatrists, doctors, dietitians, unfortunately, are not allowed to officially diagnose. But I have often, told the medical team working with the client that, hey, this person clearly meets the criteria for X eating disorder. And then they're like, oh yeah, that makes sense. So while we do have those clearly defined disorders, and I can go through what the different disorders are as well, I think it's also really important to note that not every critical, and by critical I mean like potentially medically acute, gonna die kind of person is going to neatly fit a diagnosis. Some people are going to fit in what we would think of, I don't think we really use this term anymore, but like a subclinical. They can still be very dangerous. So I don't want to say that someone needs to be diagnosed to get help or diagnosed to have this taken very seriously. And would it be helpful if I just did a quick overview of what the different eating disorders are? Okay, I'm seeing some nods. We'll go with it. Okay, so I like to think of there are kind of 4 main eating disorders, and then there are some other ones as well. So I also want to get some audience participation here. So just come off mute, and I just want to popcorn. Tell me just the name of different eating disorders that you know. Does anyone? You don't need to define it. Just say what it is.
ARFID.
Mm-hmm.
Bulimia.
Yep.
Anorexia. Yeah, I don't. Thomas, what did you say?
ARFID. ARFID.
Avoidant restrictive food intake disorder. We'll talk about what it is. Anyone else?
Compulsive overeating. Binge eating.
Yep, binge eating. Great. Those are like the main ones. We'll get into what the other ones are too. Awesome. Okay, so I'm just going to very briefly not go through the whole diagnosis of each of these, but like what kind of how they would present. So I think what most people tend to think of when they think of an eating disorder is anorexia nervosa. I also want to throw in there the term nervosa. So anorexia nervosa, bulimia nervosa means nervousness in, I believe, Latin. So usually I don't even want to say usually, like anxiety is a part of the disorder. And it's kind of like chicken and egg. Was there just anxiety present before the eating disorder? Did the eating disorder bring the anxiety? If the eating disorder goes away, will there still be anxiety? Probably. But anorexia nervosa is classified by restricting intake below the caloric needs of the individual for a prolonged period of time, along with the body dysmorphia, distortion of believing that they are fat or larger than they are, and they're very distressed about that. So some of the defining factors that kind of keep that from other ways of just not eating enough are that persistent shame and preoccupation with how their body size is experienced. Also, the current diagnosis for anorexia still has that their body weight needs to be below a certain BMI. A lot of clinicians are on the fence about if that should even be a defining feature, because if someone is fully in anorexia but is still living in a body that is above that threshold, then it isn't necessarily clinically diagnosed as anorexia, even though it is anorexia. And so we would call that atypical anorexia. And that would fit into different category, which I'm going to jump to before we get into the other one. So one that was not mentioned is other specified feeding and eating disorders. And I like to think of this as kind of the catch-all for things that don't fit into the other categories really neatly. So this can be atypical anorexia. This could be disordered eating on any spectrum. Basically, if someone is using eating disorder behaviors and they just don't meet the full criteria for one of the other things, they probably have other specified feeding and eating disorder. So just putting that in there. That could also be more I can never say that word, like different terms that we use for things like orthorexia. If we've heard of that, that would fit into the other specified feeding and eating disorders. Also OSVED is what we call it. So orthorexia is that obsession with really healthy, clean eating, however the individual defines that. Pregorexia, which is when a pregnant person, can't handle their body changing and gaining weight, and so they have anorexic tendencies, but maybe doesn't meet the full criteria for anorexia, but they're not consuming enough. Compulsive exercise could fit into OSVED category, things like that. So we'll continue on, but lots of different things can fit into that. So then bulimia nervosa. This is when someone is chronically, and I believe it needs to be at least once a week for 3 months to meet the diagnosis for bulimia or binge eating disorder, but a binge, and then with the bulimia, there's also a compensatory part of that. So whether that is purging by self-induced vomiting, over exercise, diet pills, laxatives, diuretics, dieting, probably other things that I'm not thinking of right now. So it's not just purging by vomiting. It could be purging what they consume by many different methods. So again, this behavior of binge eating, and the term binge eating is eating more than someone would under similar circumstances in a short period of time, typically defined as about 2 hours. So this isn't someone who had seconds at dinner. This is someone who's eating a lot of food. There isn't like a real hard definition of what that looks like. But yeah, I can't even explain that better. So again, with bulimia, there is going to be the distress around how they're experiencing their body present as well. And again, that is going to, that body image, body dysmorphia piece that we're seeing with these different disorders is what is also setting them apart from other clinical diagnoses that we could get to. Like if someone is vomiting all the time, for some other medical reason, but they don't have any body image issues, we wouldn't call that bulimia. That would be there's something else going on. So I just want to like separate that out as well. Binge eating disorder, similar to bulimia, it needs to happen at least once a week for at least 3 months. And that is, again, just consuming more food in a set amount of time than a person would under normal circumstances, and the feeling of how they perceive their body, not feeling good about that. Words are leaving me this moment. Oh, is there an element of loss of control in binge eating disorder? Yes. It can look different for different people, but yeah, basically a feeling like they can't stop even though they might want to. So they may feel out of control. A lot of people I talk to say that they disassociate when it's happening. It's like while they're eating, they're not even aware that it's happening. And when they're done, they're like, oh my God, I can't believe I just ate all that, or they'll see all the wrappers or something. Some people are aware it's happening, and like know that they're doing it, but they just still can't stop. So it looks different, but it is a loss of control within that. That's a great question.
I had a question. So for borderline personality disorder patients, non-suicidal self-harm is in there in the criteria, but just anecdotally speaking, I see a lot of BPD patients with disordered eating / an eating disorder. How do you differentiate whether or not that just falls within the realm of BPD and when it's actually its own separate eating disorder?
That's a great question. Yes, because eating disorder behaviors definitely can fall into the thing of self-harm. It is a form of self-harm. I don't know as much about BPD, so I'm going to start with that. I think when it becomes enough of a problem, or with that, it could be also like, is the body image piece a part of it? I think that would definitely define it into the eating disorder. And I think you would treat it like any of the other self-harm stuff. So I really like taking a harm reduction approach with a lot of eating disorder clients, right? So we're looking at, we might not be stopping or, getting at the bottom underlying issues right away, but how can we reduce the frequency, how acute the behaviors are, starting with that. And I think that might help you kind of suss out like how much of it is eating disorder versus BPD, because if it's like very easy to stop behaviors, then maybe that was just like a symptom of the BPD. If it's really difficult, then maybe the eating disorder is more ingrained than we thought. And sometimes they're going to go together. Like that's one of those diagnoses that is like, they tend to get very intrinsically linked. So yeah.
How important is it to have a body dysmorphic or a component of wanting to have a certain body shape in an eating disorder diagnosis?
Depends on the diagnosis. So the 3 that we just went through are the ones that do require that dissatisfaction with how they're experiencing their body as a defining feature. ARFID, like you brought up, that one does not have anything to do with the body image, which is why a lot of people is like, oh, is this ARFID or is this anorexia? Because the person is losing weight, not eating certain foods, things like that. And one of the things we look for, among other things, is there that body dysmorphia piece present? So I'm just going to quickly define ARFID for this, because this is one I think less people know about. ARFID is avoidant restrictive food intake disorder. This is very common with your failure to thrive kiddos, those on the autism spectrum, highly sensitive people tend, like that's going to be more likely who is going to also have ARFID, not exclusively. And so this is when someone has very specific foods that they will or won't eat for various reasons. It could be they had a history of choking and now they're afraid of solid foods and will only do liquids. Could be a texture thing where they're only eating a certain texture of food or they don't like a certain texture of food. It can be they only eat certain colors of foods, or really the rule, it looks very different, but it's not coming from like a calorie or body thing like we would think of with anorexia. So someone with anorexia might be like, I only eat these foods because they're lower in calorie, versus someone with ARFID is, I only eat these foods because they're not crunchy and I can't do crunchy. So that could be some of the differences there. This is like the eating disorder that I have a lot of trouble working with. It's very different to help someone through ARFID unless you're very experienced with it, because it kind of falls into more of exposure therapy, but doing it from a very sensitive way. And again, a lot of people with ARFID are neurodivergent. And so working, through those different pieces as well is really important. And then I'm just going to very, very quickly say the last couple eating disorders. There's rumination disorder. So if we think of like how a cow would ruminate and chew its cud, it's someone is eating, swallowing, regurgitating back into their mouth, chewing, swallowing. Yep. Doesn't happen. We don't hear about this very often, but that is a disorder. There is pica, which is the consumption of non-food substances. So you hear about people eating paper, clay, all kinds of stuff. I don't know as much about that one either. Some people say it comes from nutrient deficiencies that they're trying to find. It's just a weird thing. There's night eating syndrome and sleep-related eating disorders. One of those is just waking up in the night and eating the majority of their food in the middle of the night. The other one is literally sleepwalking and eating in their sleep, and can be very dangerous because some people are literally cooking while they're asleep, and there's been house fires and all kinds of stuff. A lot of that seems to be caused by like Ambien and those types of medications. I think those are kind of the main eating disorders. All right, so I'm done defining those. Got another question here. When would treatment or severity of eating disorder require your client to see a dietitian or medical provider throughout treatment? Always. That's the short answer. So when someone has any sort of eating disorder, disordered eating, it's important to start treatment as soon as possible. The statistics on full recovery are insanely better the sooner you get someone to start seeking help. So our typical treatment team at an outpatient level would be a registered dietitian, a mental health therapist, and a medical provider. That would be your minimum team. We can also add in there a psychiatrist or other specialists as needed, but like those three are your core at every level of treatment. So if someone is just even starting to have some issues around food and body image, I'd get them in to see at least one of those people. I also will say a lot of medical providers are not well versed in eating disorders. And in my experience, a lot of my clients have gone to their doctor for a checkup or something, and the doctor's like, oh, your weight's fine, you don't have a problem, or you need to lose weight, or you should just go on the keto diet, or you should do that. And it's like, oh my God, you just triggered them, and now they're back down a rabbit hole. So they absolutely need to be medically checked out and assessed. They should have an eating disorder expert on their team. Okay, we just got some more questions.
I asked that question, and I actually have a separate question, but as I'm thinking about like all the different specialists that are involved and thinking about the outcomes for eating disorders, I know that those with anorexia have one of the highest rates of death from their condition. I'm wondering if that is categorized as suicide or not.
I would, and I don't know the hard stats on this, I would say there's two main reasons for anorexia having such a high mortality rate. Yes, one would be suicide. I think more often though would be sudden cardiac death. So their heart literally just stops beating because there is not enough nutrients coming in. So one of the things that we really see, even early on in restrictive eating, is a lowered resting heart rate. So bradycardia. So this is someone who their heart is not beating enough per minute to, keep all the body functioning. And a lot of times what we also see is people saying, like, I'm an athlete, that's why I have a low heart rate. No, a quick way to assess for this, this I got directly from an expert doctor who works with these, is the person is, sitting, resting, has that low heart rate, and you ask them to stand up and walk across the room or walk down the hallway, and their heart rate jumps way up, that's going to be from malnutrition, not from athleticism. Because if they were actually in good shape and their heart was working because they're an athlete, their heart rate would not leap up quite a bit. Okay, we got lots of questions coming in. Let me see what we got here.
Can
Go
I
ahead,
jump?
Yes.
Am I the only parent here?
No, we have some other parents on the call.
Okay. I'm Katie Hagen's mom, and Katie definitely has eating disorder. She's officially diagnosed about 2.5 years ago. She has ARFID, and she's always underweight, and it took us about ever since she was hospitalized with NG2 for 2 months at NYU Hudson-Vale, took us this long to bring back her healthy weight. So we've been struggling with the eating disorder all this time, and getting her to eat and stay healthy is our biggest goal, compared to other stuff.
Yeah.
So when I see, the school newsletter about this meeting, I say, okay, let me attend. So Libby, are you based in New York?
I am.
Okay. So just in case we need to reach out to you for help or anything like that, I would love to,
Yeah.
get.
And I'll also just put in there, so I'm not taking individual clients, but I have a really good network of people, so I can help connect you with other providers. Absolutely.
Okay. Great. We were with ever since she got discharged from what was the place, after from Hudson-Vale to what's the NYP place? Outlook.
Oh, New York Presbyterian.
It's Outlook their eating disorder program. And then we were with Equip.
Mhm.
Yeah. But she's relatively good. My question is, lately, she refused all the proteins. So getting protein in is the biggest issue for us.
Mhm.
So just wondering, trying to get some tips.
It's hard not knowing, what she is eating and more of her case and everything. Does she do liquids at all? Are you able to do like milk or protein shakes or anything?
No shakes. That's the
Okay.
biggest problem. No shakes, no supplemental drinks. She will eat some eggs in specific way, only that type of cooking. And she would have some salmon, but lately just seems to, again, eating less and less proteins.
Yeah.
So yeah.
This and I want to preface this with I am not an ARFID expert. But in this kind of case, this is where I would say, like, lean into the things that she will eat. So if she will eat eggs in that specific way, then maybe for the time being, you're making eggs every day. This is where you want to kind of cater to that. And I'm sure, like, you probably know a lot more about ARFID than I do, having gone through Equip and everything with her. So for those of you that don't know, Equip is a family-based virtual treatment program. So they're, as far as I know, they're working really closely with the parents as well. So they've probably taught you some skills on like maybe expanding textures of foods and things like that. So maybe starting to kind of work with that. So if she's eating eggs in one certain way, say like, okay, I'm going to make you an egg that way, and I'm going to make another egg just slightly different. I want to see if you can take a bite, and, you know, slowly working up like that, or working it into other foods or something. Don't have a better answer for you right now. I'm sorry.
Problem.
Okay. And for the sake of time, I'm going to jump into some other questions, but feel free to email me. I'm happy to connect you with people if needed.
Thank
Okay.
you.
Of course. I'm going to look through. Okay. Are there child-specific eating disorder assessments, both interview and independently completed self-report, you recommend incorporating into treatment as markers of intervention success? Child-specific. That's a great question. I know some good validated eating disorder assessments. I don't know if they're appropriate for children or not. I pretty much just work with like older teens and up. But the ones one that I like to, particularly for like self-reported questionnaire, to do like when I was running groups, I would do it as a baseline and then like 3 months and see how it changed, is the EAT 26. So EAT-26. That is a 26 question questionnaire that has a number assessment. So it's interesting to see if the number changes over time. But in terms of like using it as more of a diagnostic feature, I want to say there is a child specific one. Liz, is this something I could send? If I find it, send it to you and you can send it out to everyone?
Absolutely. Yeah. Yep.
I will try to remember to take a look for that. Yeah. And Thomas, what is there a specific like age range you're looking at for child specific? Do you want to tell me what that age range is?
Anywhere from 5 to 18.
Oh, okay. All right. I will see what I can find. Okay. All right. What are your thoughts on criteria for starting a food log tracking student food consumption, and whether or not a student exhibiting disordered eating or with significant weight gain or loss should be informed that they are on a food log? Julia, I'm going to ask for a little more clarity on that, please.
Sure. Yeah. So I'm at a residential treatment center for adolescents. So when our medical staff observe a medically significant weight loss or weight gain or a pattern, so our residential staff just notice that students either tend to skip meals or to binge meals, that typically triggers us to put the student on a food log, which means the residential staff monitor what and how much food is being consumed at each meal and write it down in a log, so that if there's a pattern of missed meals, I think it's 3 consecutive missed meals, we go to a more supported eating protocol. And I'm just wondering about the clinical efficacy of this as an expert in eating disorder. I'd love your perspective in particular on whether or not it would be supportive for students to automatically be informed that they're on the food log, as opposed to our current practice, which is that the students do not know.
I don't know ethically, but I kind of like what you're doing, because I think we know that when people, you know, it's the same thing, like if we start tracking our own habits, we might make changes that we wouldn't otherwise do. If someone's going to be sneaky with their food, like if they know you're tracking, they might eat differently during the meal and then might do something when you're not seeing them. So it could be, sure, I eat my meal, but now that I can't skip it, I'm going to go throw it up, or I'm going to you know, go get candy and binge it in my room or something. So I think kind of just having that, you know, step back observation without them knowing you're seeing what they're actually doing. So I'm not mad about that. Um, I don't know, is that enough of an answer for you?
It is. What I'm hearing you say is for assessment, it's a practice you're okay with. I'm really curious about the best practices around supporting students with disordered eating in getting back on track. It's an area where I have minimal
Yeah.
training and would like to learn more. So any resources you could point myself and other clinicians to would be great.
I'm gonna grab a link from my website. So I have a list of books that I really love for eating disorders, and I have it broken down like for clinicians, for people struggling, for families. So let me grab that really quick, and I'm gonna pop it in the chat for you because I have my website pulled up. So let me grab that. But also, if it is something that you're wanting to learn more about eating disorders as a clinician, I highly recommend getting some clinical supervision. So that's something, I mean, I even offer supervision. Lots of eating disorder professionals offer supervision, and it's where you can ask, more in-depth questions like this. You can present cases and work through cases. So supervision is really, I think, imperative in the field because it is something that's not really taught in school. And as far as, ways to support the students more, I think a big piece of it is just kind of the whole environment of the program. I don't know where you work or what that looks like, or, you don't need to go into that for this, but, making sure that food and body image are very neutral topics. So we're not like, we're having healthy meals, or you need to eat your vegetables first, or this has so many calories. We want to just keep it very neutral, and being like, oh, that looks yummy, or I'm eating, not putting any like good or bad food labels on stuff, I think is incredibly important. This is for everybody. This is great stuff for just working with humans in life, not even necessarily in a therapeutic setting. And what else do I want to say about that? As far as like the supportive eating, taking some time to also process feelings before, during, and after eating. I don't know what it's looking like, at your program, but, doing check-ins with like, are they noticing their hunger and fullness cues? Why, is there any situations or emotions that are causing them to want to do these behaviors with food? Did someone say something and now they feel shamed to eat, or are they really stressed because something happened? And, trying to help them, because eating disorders, at really the core of it, are coping mechanisms. So food is not addictive, and I want to make that very clear. But eating disorders are a process addiction. So similar to how someone would use drugs or alcohol, they're using food behaviors typically to numb out or get away from a situation. So it could be like if they're in a very stressful environment, they might be either, restricting or binging as a way to not have to think about what's going on and to be able to just kind of step back for a moment. It's very numbing for a lot of people. I think I don't know if I want to go as far as a common misconception, because sometimes this is a thing, but a lot of people think eating disorders are about control. Sometimes, but I would say more often than not, it's really a way of almost trying not to have too much control for a moment, being like, I just need to just get away. So it gets almost dissociative. And so overthinking, on the restrictive side, if someone is just like thinking about food all the time, they don't have space in their brain to think about the other stuff going on in their lives. Or like, I'm going to focus on, I can only eat these things. What did I already eat today? Okay, I can have that, but I have to go to this thing later. What am I going to eat? I used to have a restrictive disorder, so I know how that spiral goes in the brain. It's just you constantly thinking and talking to yourself. And on the, binging side, it's, I don't want to think about this thing. I'm going to try to push it out by feeling full. I'm going to try to find comfort love, feel loneliness void, eat so I can numb out. And, again, similar to perhaps someone binge drinking, it's kind of that numbing sensation of, in the moment, it's very numbing. And then afterwards, it's oh God, what did I do? So these are coping mechanisms, not things that are going to actually fix their life. And so being able to kind of talk them through, like, okay, so what is the reward that you're seeking out of this? And asking, when you do this thing, what about it feels good? Because the disorder serves a purpose. It's problematic in the long run, but in the moment, it is giving them something beneficial that they really need in that moment. So looking at, okay, what other coping mechanisms could we use that are going to give you a similar reward that's going to help you feel better in that moment, that aren't going to be so self-destructive? Let's see what other questions we got here. Okay. How can schools support with the management, identification, treatment of eating disorder? Oop, it just jumped. Eating disorders. What do you usually want schools to do to support your clinical efforts? Great question. So we talked about a little bit of this, but I think schools, and especially schools like yours, where you have so much one-on-one interaction with the students, like no one is getting lost in the shuffle, like maybe a big public school or something. It's probably easier to be that first person really noticing what is going on with the kid, that something is off, that they're, doing weird things with food or talking about body image or whatever. So it is not your responsibility to diagnose the eating disorder, but if you notice that something is up, reach out to, I'd probably start with talking to the student, and then, depending on age appropriateness and all that, talk to parents, family, to see, this has been coming up. We don't want it to become a bigger problem. We should have them, go to a specialist. I would typically start with either a therapist or registered dietitian that is a specialist with eating disorders. And again, this is something where, so the consulting work that I do is I help with placement at all levels of care. So if someone is struggling, I have a nationwide network that I can do a quick assessment on the client, say, okay, this is what's going on, this is the level of care that we recommend, and then help match them with appropriate resources, whether that's individual providers or treat me for that kind of work. I do charge for that service, but at a minimum, I would find a therapist or a registered dietitian that works with eating disorders to get them started. And if you find just one of those providers, they're going to be able to help set up the rest of the team for the person. So that was really where I would start. If the child or parent is very adverse to wanting to do treatment, maybe starting with some educational resources, as well as I would continue monitoring the student. So that could be, sending some readings or podcasts or something to the parents, whatever you think they're going to be receptive to. And again, on my website, I have some resources for that kind of the students. That could also be, having short little snippets of stuff. So maybe not giving them a whole book on the topic, but like, oh, here's an article or a podcast, or your, favorite celebrity who went through an eating disorder or something, and have them kind of normalize that, oh, this is a thing and it's worth getting help. Okay, we got a lot of questions coming in. Let's see. You talk about family involvement in treatment as well. When does that come in? Is it always necessary? I'm in an eating disorder lab with my program. My supervisor often mentions inviting the family in for meals. Great. That is a good and complex question. So social support is one of the main things that we see being helpful for full recovery in eating disorders. Depending on the family dynamic, it's not always going to be the parents. We hope it will be the parents, especially if it is, an adolescent living at home. But as long as they have, I'd say, at least one really solid person they're spending time with who is helpful and supportive to their recovery, like that is key. If they are living with their parents or anyone that they're living with, it is really helpful to get the family involved, because if the parents don't know how to talk about this, how to eat with their kid, they can be really triggering. Parents should not be the food police. They should not be, talking again, like we don't want to categorize food as good and bad, healthy, unhealthy, that kind of stuff. And so having some parent coaching around mealtime can be incredibly helpful, just so that if nothing else, they're not making it worse. And if they're doing it well, they can absolutely be essential in helping the child move forward. And again, depending on age appropriateness, the parents might be needing to make and plate the food or review that the kid put enough on their plate or, things like that. So I think it's very necessary if it's going to be appropriate. If it's, a negative environment, then maybe we need to find someone else who's going to spend time with the kid that can take on that role as well. But I think parent-family education, always. You don't know what you don't know. And I've worked with parents at every level of knowledge on this. And if you haven't gone through an eating disorder yourself, how do you know how to talk about this? I always say to my clients and their families, like, there's no reason that you should know how to navigate this process because hopefully you've never gone through it before. And, even as clinicians, it can be difficult because there's so many multifaceted pieces to this. So education, like it's not a shameful thing to have more education on this. So, all right. Are there different presentations of these disorders that you've seen in varying cultural contexts? Absolutely. I don't know how to answer that. That's a big question. Yes. If you want to ask a more clarifying question, go for it. Otherwise, if anyone else has questions.
I was wondering if you could kind of expand on how you balance like those like cultural features of eating and food, especially with more of the medical interventions that are like biologically driven, and so like how you balance out those like cultural patterns with the actual like medical interventions.
That's great. Yeah, so we definitely want to take cultural considerations into this because different cultures eat and view food and body image and all of that and medical intervention differently. So we want to be very sensitive to that. I always like to come from a very questioning and motivational interviewing place with anyone I'm working with. So I want to ask a lot of questions around, what, on a very like simplistic level, like, why do you eat this way? What is important to you? And if I know stuff is cultural, like, what is really normal for you? What is normal for your culture? Also kind of different eating patterns are like around the world in different cultures. So having some understanding of that and knowing that the way that I eat as a white American is going to look different than someone from somewhere else. And that is fine. But when we're looking at, on a nutrition side of things, like looking at, are you getting an appropriate amount of these different categories of food? Like that's going to be the same across humans, but the specific types of food might look different in those categories. cool, as long as they're hitting that stuff. And then in terms of like getting medical intervention, because yes, some cultures, maybe don't want Western medicine, or they see things differently. So that's kind of, again, looking at how acute is the problem versus where can we kind of meet in the middle with stuff. If someone is very medically compromised, I really try to emphasize, like, we need to take action now, and this is the steps that need to be taken. Like if they need to go to the hospital or they need fluids or something like that, like we need to act fast, or your kid's not going to be around tomorrow, if it's something where it's not super acute, maybe we look at like, okay, what would you normally do for this? My potential flaws, I can be very blunt with people. Like, I'm not going to sugarcoat stuff. I'm going to say like, this is what needs to happen. But if there's something that's not going to harm someone and it fits into their culture, then I think that's fine. But we definitely want to make sure that if we need to take medical interventions, that I don't have a great way to answer this without having like a really specific case, I guess. Really awesome. Any other questions?
I did actually have one more. I was wondering if you could just quickly highlight like the common myths that maybe people have about eating disorders, just so we can have that in the back of our head.
Yes. I think one really important thing to know is that eating disorders don't have a certain look. It literally could be any age, any gender, any size, any ethnicity, any socioeconomic status. Like, it is not the, thin white girl teen that, a lot of people I think of when they think of an eating disorder. Most people with eating disorders are walking around in, normal size bodies. They're not going to present on either end of the weight spectrum. Again, most people with eating disorders are very good at hiding it. So you might not notice it unless you're spending a lot of time with that person. There's some other myths. We kind of covered the myth that it's often about control. It's usually more of a coping mechanism than it is control. Which I guess that could be seen as a form of control, but what else? It's not just a phase. It's not just picky eating. These are really complex mental health disorders that present behaviorally through food, body image, and exercise, and can turn into really serious medical problems. As someone brought up earlier, anorexia nervosa has the second highest mortality rate of any psychiatric illness, second only to opioid overdose. So these are really serious, and all the different types of eating disorders can become very serious. So this is not something that should be ignored. I probably could come up with more, but if anyone else has questions, I'll take that for our last 5 minutes first.
How do you manage the level? How do you manage a patient who has very low motivation to change the eating disorder and really, really identifies with the way they rationalize that they're just not hungry, and yet we do know, as I said, just how gravely serious it is to treat.
Yeah. Well, assuming they're not like needing to go to the hospital right now, because that's always something to be assessing for. I really work through the stages of change trans-theoretical model. So if someone is at that pre-contemplative phase, I'm working on just getting buy-in, right? This is the same type of motivational interviewing counseling skills that you could use in any situation. So, okay, you don't think you have a problem. So I'm going to try to lay out all of the hard evidence first, knowing that they probably still won't believe me, but it's like, okay, these are the eating habits that we've been noticing. So this is where, gosh, was it Julia? I think you were saying like keeping that food log, like this can be helpful for laying out the evidence if someone is really like, I don't have a problem. It could be if you have, lab values or you've noticed weight changes, things like that, like having that hard evidence can be helpful, not always, in helping them understand that something's going on. I also think it's really important if you're trying to bring up that you're concerned about someone, using I statements. So I've been really worried about you because I've noticed blah, blah, blah. I'm concerned that blah, 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 like using those I statements, very important in how we're addressing someone who is maybe not ready to hear that yet. We don't want to be accusatory. We don't want to be like, you don't eat, you do that. No, I'm worried about you because I've noticed that you are blah, blah, blah. That can be really helpful. And then assuming that they're willing to work on anything, like literally starting with anything they're comfortable doing. Most of my clients, whether or not they are at a place where they want to be working on this, usually we can find like one little action they can take. Like if it's someone who is really restricting their eating, it might be like, can you take 2 more bites at lunch? Can you add an apple to your day? Like something small and tangible that, and I would even ask them like, what do you feel like your first step would be? Like what is something that you would feel comfortable adding? Or asking those types of questions and just starting with where they're at. This is where, again, we're taking kind of a harm reduction approach to it. And if they're still really fighting it, this is where we might need to get other people involved. So if you know there is someone who is very influential in their life, a best friend, a mentor, they're really close to their parent, whatever, having that person also talk to them in I statements, maybe get some education themselves before they talk to the individual, so they can really come at it from the right angle to try to get some buy-in, and know that just by bringing it up that you are planting seeds. So again, hopefully, it's not super deep at this point and you can plant the seeds, and in a week or so they'll come and be like, okay, I actually do want help. If it is more medically advanced, obviously you might need to actually take action on that, but making sure that when you're bringing it up to someone, if they're not ready to receive help right then, that you're a safe place. Like, if you want to talk, I'm here. If you want more resources, I'm here. I can help you get help. I can help you find education. I can help you find a provider, whatever that kind of thing is. And just making yourself a really safe person. Because I think that having that trust and safety to come to someone is going to make them more likely to open up, talk to you, and actually be willing to work on it.
Any last questions? Because we are at time.
These have been such great questions. This has been fun.
Yes, they came prepared. But no one has anything else. Thank you so much, Libby. Appreciate your expertise. If you want to, do you have your email that if you want to put in the chat, or I could follow up with everyone with that?
I'll put it in the chat, and if you want to send it to everyone.
Yeah.
It's at BroadwayDietitian.com. Please reach out with questions, clients, whatever you got. I put my website in the chat already.
So thank you so much for your time. We appreciate it. Please use her as a resource, please.
And
And
I'm in as well. So for those of you around here, I'm available.
great. And in 2 weeks, we'll have our last lecture of the year. It'll be about collaborative problem solving. So join us then. And thank you all. Thanks again, Libby. Have a great rest of your day.
Thank you.
Bye.
Bye, everyone. Thanks.